So I'm very happy to introduce our next speaker, who is a pharmacist and intimately knows the ins and outs of that therapy. So I would like to actually introduce to you at this time pharmacist Onyinye Isiguzo, who's an assistant director of pharmaceutical services in the Federal Medical Center, Owerri, Nigeria. She's an active member of the local Bloodless Medicine and Surgery group there in her institution. She's also a member of the Bloodless Medicine and Surgery Society. She's a strong and passionate advocate for transfusion-free medicine, and she's a patient's right advocate. So I'm going to turn now the program over to her. Thank you so much.
Thank you for that introduction. Thank you all for the opportunity to speak at this week's Bloodless Surgery program. So erythropoietin is a familiar name in bloodless medicine and surgery. So it's important that we talk about it, what it is, what it's used for, how it's produced. And we also want to look at other functions it might have in addition to optimizing the haematocrit. So what is erythropoietin? It's actually a glycoprotein hormone that is produced in the body, mainly in the adult kidney. And some is also produced in the fetal liver. Erythropoietin is a primary regulator of erythropoiesis. It is not the sole factor responsible for erythropoiesis. There are still other factors that are responsible for erythropoiesis. However, it is the primary regulator. Its main stimulus, the main stimulus for its production is kidney hypoxia. And it acts mainly on the committed erythroid progenitor cells, with the boss-forming unit erythroid cells and the colony-forming unit erythroid cells are the ones that show high dependency and more expression for erythropoietin receptors. Once it acts on these cells, it stimulates their proliferation and differentiation into mature red blood cells. So, how did we come to know about erythropoietin? The story behind it started about a century ago. There are some French investigators that realized that a small amount of plasma gotten from anemic rabbits that were injected into normal animals caused an increase in red blood cell production within a few hours. They were interested in this activity and they referred to it as haemopoietin. They wanted to understand more as to what caused this activity. And this investigation led them to realize that a single protein was responsible. The protein was found in the blood plasma and that it was responsible for this action. Initially, it was referred to as an erythropoietic stimulating factor, but finally, it was given the name erythropoietin. More investigations were carried out by American investigators. They now refined the work of these French scientists and proved conclusively that there was a hormone responsible for that production, and that is erythropoietin. They continued investigations that now led them to understand this hormone better as to how it was produced, what stimulated the production, people who could benefit from it, and is there any other way to produce it outside the endogenous one? By 1983, they discovered a method for mass producing a synthetic version of that hormone. How is erythropoietin produced? We came to understand that erythropoietin was produced in the peritubular interstitial cells of the kidney under the control of a single gene on the human chromosome 7. The gene product is a protein containing about 193 amino acids. The first 27 are cleaved during secretion. And the final hormonal peptide is heavily glycosylated and has a molecular weight of approximately 30,400 Daltons. This erythropoietin, once produced, travels down to the marrow. At the bone marrow, we have the erythropoietin receptor sites, which are found on the surface of committed erythroid progenitors. Once it binds at that the receptor sites on this surface, on this committed erythroid progenitor cells, it becomes internalized. At this, we also want to understand that there is an inverse correlation between tissue oxygenation and circulating EPO levels. Once the tissue oxygenation is normal or optimum, the circulating erythropoietin levels will be low. But once there is hypoxia, there is increase in the circulating erythropoietin levels, since anemia or hypoxemia would cause increase in renal synthesis of erythropoietin. So the serum erythropoietin levels will rise. Marrow progenitor cell survival, proliferation, and maturation will also be dramatically stimulated. However, this finely tuned feedback mechanism could be disrupted at any point. We've seen that it's mainly produced in the kidney. If there is a problem with the kidney, or there is a damage to the bone marrow, or maybe there is a problem or a deficiency in iron or the other essential vitamins that are responsible for the production of red blood cells, this finely tuned back loop could be disrupted and there will be problems. Also, when there is an inflammation, in inflammatory states, we realize that erythropoietin secretion is usually suppressed by the inflammatory cytokinins. Iron delivery and also progenitor proliferation are also suppressed by these inflammatory cytokinins. So what could be done? How do we help patients in this kind of state? These limitations to endogenous production led to more research that now brought about a technology that was able to overcome all these limitations. It's a technology that involved a combination of medical and molecular engineering. And this gave rise to the recombinant human erythropoietin. What is this recombinant human erythropoietin? It's a therapeutic agent produced by DNA technology in mammalian cell culture. We could say that it's a synthetic form of erythropoietin. And it's virtually identical to the naturally occurring hormone. That is the naturally occurring erythropoietin. There are about 5 types of these that have been synthesized over the years. We have the epoietin alpha, delta, the epoietin beta, the epoietin omega, delta, and the double epoietin alpha. All these agents have the same amino acid sequence, but their glycosylation varies as a result of the type and host cell specific differences in the production process. The epoietin alpha is the first recombinant erythropoietin to be synthesized, which happened in 1983 when the gene coding for erythropoietin was first identified by the American Genetic Research Corporation, Amgen. They patented the drug under the name Epogen. It has about 165 amino acids with a molecular weight of approximately 30,400 Daltons. You see that? Very similar to the endogenous one. And it was produced in mammalian cells into which the human erythropoietin gene had been introduced. This erythropoietin alpha is formulated as a colorless liquid in a solution of sodium chloride buffered with a sodium citrate or sodium phosphate. It's packaged for injection in 1 ml vials. It's a pre-filled injection. It comes, you can have the 2,000 international units, 4,000, even as high as the 10,000 international units of epoietin alpha. However, it has to be stored in the refrigerator between -20 degrees to -70 degrees. It doesn't need to be freezed because freezing would make it lose its efficacy. However, if heat denatures it, because we know it's a protein and heat could denature proteins. So we have to be careful whenever we are sourcing the epoietin or this recombinant erythropoietin, we have to be careful where we are getting it so that we do not get something that will not work. Then the next one to come into the scene is the epoietin beta, initially marketed as Recomon by a German company which became part of the Roche group. It's similar to epoietin alpha with respect to molecular characteristics and pharmacokinetic data. However, there are a few differences in that it has higher molecular weight and it also has lower number of silated glycan residues. These differences could account for slight pharmacokinetic advantages, such as a longer terminal elimination half-life against the erythropoietin alpha. The erythropoietin beta is packaged in peripheral syringes, just as the erythropoietin alpha, and it comes in these solutions with urea, sodium chloride, sodium phosphate, and water. That's all part of that injection. It also has to be stored cold chain, stored and transported cold chain, like every other recombinant erythropoietin. The third one that came into the world scene was erythropoietin omega, and is a sialoglycoprotein with smaller amounts of O-bond sugars. It has less acidic, and it's less acidic and has a different hydrophility than the other two erythropoietins. A study on efficacy and safety of this erythropoietin omega showed that its efficacy and safety is comparable, is as safe and as effective as the erythropoietin alpha. Then the next was the erythropoietin delta. This is quite unique. It was produced directly in a human cell line using gene activation technology. All the other ones, it was in mammalian cell cultures, but this is the only one that has a human type glycosylation profile. It is equally as effective as the erythropoietin alpha, and it was marketed, it was patented by the Shell Pharmaceutical company, marketed as a Dynepo. However, by 2002, the European Medicine Agencies withdrew the authorization they gave to the company to market it, still under investigations as to why. Now we have the double erythropoietin alpha. This is a further re-engineered form of erythropoietin. Some changes were done, about 5 amino acid changes, which now resulted in the creation of 2 new sites for end-linked carbohydrate additions. And these modifications made it to have a longer serum half-life compared to the alpha and the beta. And it has increased biological activity in vivo. It's marketed by Amgen under the trade name Aranex. How does erythropoietin act? Its main function is to recruit, maintain, and induce the differentiation of erythroid progenitor cells. The burst-forming unit erythroid are the most primitive erythroid progenitor cells in the erythroid pathway. They are the ones that primarily respond first to erythropoietin. However, they require the synergistic action of erythropoietin with interleukin-3 or the granulocyte macrophage colony stimulating factor to start their differentiation into a colony of recognizable red blood cell precursors. Whereas the colony-forming units, they are completely dependent on erythropoietin for proliferation, viability, and differentiation. However, their dependence declines as the differentiation process proceeds through the late stage. The proerythroblast is usually which is a progeny of this colony-forming unit erythroid cells, is the earliest morphologically recognizable red blood cell precursor that is seen in the bone marrow. And it does not require erythropoietin for its maturation to reticulocytes. Then we move to the dosing and administration of erythropoietin. This table shows how the dose of erythropoietin alpha and beta is usually calculated, and it's dosed per kilogram of body weight per week. We see that the more the weight of the individual, the more units of erythropoietin that will be required to achieve good results. Then, patients who do not respond to this initial dosing of about 4,000 units per kilogram per body weight, 450 units rather, patients who do not respond to this, they could receive double the dose. So it's very safe and they could still achieve the same efficacy results when the dose is doubled. Usually for erythropoietin alpha and beta 2, which are the two erythropoietins that are more in use, they are usually dosed between 100 to 150 units per kilogram body weight, given subcutaneously 2 times weekly. And this should be done for a period of 3 weeks. That's the patient should be receiving like 6 doses. And when you do this, you realize that erythropoiesis is increased to about 4 times the normal basal marrow red blood cell production. And we'll see reticulocyte counts by day 3 of administration of erythropoietin. The HB rise also is about 1 gram per DL every 4 to 7 days. For the long-acting erythropoietin stimulating agents, that's the darbepoetin alpha, you could either do weekly or give a bolus infusion in every 3 weeks. But like we've seen, there is no magic. You get better results when you start ahead of time. Whether erythropoietin is given subcutaneously or intravenously, it is usually well absorbed. However, the subcutaneous route is preferred. The reasons are clear. For the intravenous route, the peak serum concentration takes a shorter time to be achieved. But once it's achieved, usually within 1 hour of administering erythropoietin intravenously, you achieve the peak serum concentration. But it clears out of the system as fast as it's achieved, and hence its effect is not sustained for a longer time. Whereas for the subcutaneous route, the peak serum concentration duration is quite longer, and it declines. And for it to get eliminated, it declines slowly thereafter. That is why for the subcutaneous route, you have the half-life coming to about 24 hours, whereas the intravenous route, within 4 to 13 hours, it is cleared off the system. And since the subcutaneous route declines slowly thereafter, you realize that you require lower dosage to produce comparable effects as the intravenous route. A study was carried out whereby patients were given about 20 to 30% lower doses as that was given intravenously. And the results were very comparable as regards the efficacy. And with the subcutaneous route, there are lower incidence of adverse effects. It's clear why that will be so. It's also found to be more effective in hemodialysis patients, and it's more cost-effective as lower doses are being used. When the volume of distribution was also examined, it was realized that it's similar to the plasma volume. So no matter what route you use, nothing is trapped in the tissues. Everything is available for use. What are the indications for erythropoietin therapy? One, we have the kidney disease patients. During the course of the introduction and its production, we've seen why these patients would require the recombinant erythropoietin as their body is not producing more. Then in AIDS patients who are on antiretroviral therapy, we have zidovudine as one of the antiretrovirals that cause anemia. Hence, patients receiving this medication would require the support of erythropoietin. Then perioperatively and in postoperative settings, when we want to stimulate patients' red blood cell production, erythropoietin is the drug of choice. In acute surgical and in the post-operation period, erythropoietin helps for more rapid recovery and is also a useful adjunct following perioperative hemodilation. In chemotherapy, some patients who are undergoing chemotherapy have chemotherapy-induced anemias, and erythropoietin could be very effective in these patients. Then, for patients who do not want allogenic blood transfusion, such patients would benefit from erythropoietin. Then in neonates, erythropoietin is also beneficial in the treatment of anemia of prematurity. In these neonates, erythropoietin showed good effects as regards there is overall benefit in developmental assessment and in cognitive development. It was also observed that it reduced both the morbidity and their mortality rates. as thrombolytic therapy is usually not preferred in this group of patients. However, erythropoietin effect goes beyond its use in optimizing the hematocrit. Erythropoietin has been seen to cause some multi-tissue responses associated with erythropoietin receptor expression in non-erythroid cells. Some of these cells include the endothelial cells, the brain cells, the skeletal muscles, the bone cells, the fat cells, and the heart cells. The expression of erythropoietin on the receptor of these cells has brought about good results. However, these studies have been carried out in animal models more than in human models. Then we want to look at the endothelial cells. The endothelial cells are the first cells to show erythropoietin activity beyond erythropoiesis. In the endothelial cells, we know that the endothelial nitric oxide synthase produces nitric oxide, which is a potent vasodilator. Erythropoietin has been found to stimulate these endothelial cells and activate the production of nitric oxide, particularly at reduced oxygen levels. And when this is done, we see that there is improved tissue oxygenation, as this provides a potential for an acute response, regulating vascular tone and blood pressure, because the nitric oxide opens up the vessel. So even when the blood volume is low, there is more being pumped in, and there is improved oxygen delivery. Then the cardioprotection. Erythropoietin, when studied in rats, proved to have cardioprotective effects. Some mice that lacked erythropoietin signaling, it was found that they exhibit ventricular hyperplasia, indicating defects in proliferation and expansion of the myocardium. Erythropoietin also promoted cardioprotection in ischemia perfusion injury in isolated adult hearts from rodents. Its administration in rabbits also was protective for myocardial infarction. In some adult rats, when erythropoietin was administered immediately after a myocardial infarction, it was noticed that the infarct size reduced, which was linked to opening up of new vessels by erythropoietin. It was also observed that delayed weekly erythropoietin treatment beginning 7 days after coronary occlusion in rats resulted in reduced injury and improved cardiac function associated with mobilized endothelial progenitor cells. Then, in the neurons, it was found out too that there are some erythropoietin receptors in the neurons and in some other locations in the brain. And the astrocytes and neurons in the brain cells, they produce erythropoietin in a hypoxia-inducible manner. It was also observed that animals that showed erythropoietin deletion in their neural cells exhibited reduced neural cell proliferation and viability, and also increased their susceptibility to glutamate damage and stroke. Erythropoietin preconditioning also proved to be protective for ischemia or middle cerebral artery occlusion, cerebral artery occlusion-induced learning disability, and neuron death in animal brain. These studies were tried also in humans. The phase 1 clinical trial in humans with stroke showed promising results. However, when they moved on to the phase 2 and the phase 3 clinical trials, the results were not as favorable as the phase 1. Hence, more studies are required to show that erythropoietin could be neuroprotective in humans too. Then, in skeletal muscles, it was found out that erythropoietin stimulated myoblast proliferation and survival by increasing the DATF4 and the TAL1 that usually retarded myogenic differentiation. So, with erythropoietin stimulating this, myogenic differentiation was able to go on without being stopped. And hence, mice that were subjected to skeletal muscle injury exhibited improved muscle repair and recovery. And even the maximum load that could be tolerated by the isolated muscle was also increased. And this could explain why some athletes tend to abuse erythropoietin. Then, in the fat cells, animal studies show that erythropoietin may also be protective in diet-induced obesity. We know that in diet-induced obesity, glucose tolerance usually is poor, and there is increase in insulin resistance, and there's also more fat mass accumulation. Erythropoietin was found to improve glucose tolerance, reduce insulin resistance, and also regulate fat mass accumulation. However, this regulation in fat mass is gender specific. It happened particularly in the male mice. The reason is obvious. Estrogen is found in females, and estrogen can affect the action of erythropoietin through direct regulation of its production or even modulation of tissue-specific erythropoietin response. Hence, it couldn't regulate fat mass in females. Then, this effect of erythropoietin in adipocytes also led to understanding something that happens in residents of people who are resident at the high altitude. We know that for such people who reside at high altitude areas, there is lower oxygen tension, and as a result, the erythropoietin levels are quite higher. So it could explain why most of them, especially the males, are slimmer. And when we see the East African long distance runners, we see that they have no problem with obesity, and more of their males are on the slimmer side, not on the obese side. So this reduction in fat mass could be a reason for that. Then in the bone cells, erythropoietin was also found to improve bone healing. However, more studies also reveal that when erythropoietin is given in elevated doses, it could be detrimental to the bone formation. So the giving of erythropoietin, the more studies need to be carried out in order to understand clearly at what dose would it help to improve the bone healing and repair, and at what dose could it be detrimental, since it resulted in significant bone reduction in some healthy animals who received this erythropoietin. Now, there are interactions with erythropoietin. Having seen all the sites, all the areas that erythropoietin could be effective. Yes, there are. We have both the food and the drug interactions. Foods that contain iron, folic acid, or vitamin B12, such as eggs, certain cereals, meats, and vegetables, they can assist erythropoiesis, since these vitamins are all essential in erythropoiesis. So when a patient is receiving a poietin therapy and is on this kind of foods, there would be better, the results will come out better. Then vitamin A has also been found to increase the production of erythropoietin. So we expect that a patient who is on foods rich in vitamin A, like palm oil, carrots, sweet potatoes, cantaloupe, and is also on a poietin therapy, there will be a synergistic response. However, patients who have type 2 diabetes, when they are given fresh pomegranate juice, it was realized that it decreased their fasting serum erythropoietin. However, this result was not observed in normal patients. So it's mainly in patients with type 2 diabetes. So when they are on a poietin therapy, it will be better they avoid that juice. Drug interactions. Immunomodulatory agents like the lenalidomide, the pomalidomide, the thalidomide, when given concomitantly with erythropoietin, might increase the risk of thrombosis. Also, chemotherapeutic agents like doxorubicin, bicalutamide may also have the same effect when given concomitantly with erythropoietin. whereas belzotifan was found to increase the adverse effects of erythropoietin. These are more major interactions. The minor interactions that were observed was seen in the angiotensin converting enzyme inhibitors like captopril, enalapril, perindopril, lisinopril. It was shown that they could decrease the serum concentration of erythropoietin. So patients who are receiving these medications or who might be given this medication because of the side effect of erythropoietin, this should be put into consideration. Then the C1 esterase inhibitors may also increase the risk of thrombosis, as they also have thrombogenic effects when given concomitantly with erythropoietin. However, parenteral iron preparations should be given with erythropoietin as it will improve its efficacy. We've seen how this production goes on. More synthesis of erythropoietin leads to increase in red blood cell production. And one of the important vitamins in red blood cell production is iron. So if there is increase in erythropoietin and you are not supplementing iron, you could trigger an iron deficiency in this patient. And from Prof stocks, we see that some patients, their iron stores might be very low, even though they are not anemic. So it's good to supplement epoetin therapy with parenteral iron preparations. Iron supplements, whether oral too, could be very effective, but not when there is you are going in for surgery or there is an immediate need for increase in the red blood cell volume. So multivitamin supplements containing vitamin B12, folic acid, and vitamin A will also improve its efficacy. However, there are side effects associated with this epoetin therapy. Usually, it's observed that with intravenous erythropoietin, there is increase in blood pressure. This is thought to be as a result of rapid increase in the haematocrit. For that same reason, some patients may also develop clots, blood clots. This increase in blood pressure is not so common when the drug is administered subcutaneously. And it can also be managed with antihypertensive agents. Another side effect that was observed with erythropoietin is what we call the pure red cell aplasia. It's usually an autoimmune reaction that some patients had towards the recombinant human erythropoietin. But most studies show that this reaction may not be due to erythropoietin itself, but rather due to the effect of the leeches from the rubber stoppers that were used in the prefilled syringes. And some modifications were done to resolve these issues. And ever since then, newer cases of this pure red cell aplasia has become very, very rare. There are other minor side effects. They include diarrhea, dizziness, headache, itching, muscle aches and pains, nausea, vomiting, pain at the site of injection, tiredness. These side effects are usually seen when the patient just started receiving an administration of erythropoietin, but they gradually disappear as the patient's body adjusts to the medication. Contraindications. When a patient has hypertension and is uncontrolled, we've given antihypertensive agents and the blood pressure is not coming down, it will not be advisable to use erythropoietin. Patients with known hypersensitivity to mammalian cell-derived products would also react to erythropoietin, so it's contraindicated in such patients. Or patients that have known hypersensitivity to albumin, or patients that have coronary artery disease. In such patients, something that will increase the red blood cell production might cause the formation of clots, as their arteries are already narrowed. Then in iron deficiency anemia, erythropoietin is not the drug of choice. We have to treat the iron deficiency by giving a parenteral iron or oral iron, as the case may be. In anemia due to vitamin B12 or folate deficiency, erythropoietin would not be necessary in correcting this kind of anemia. And also in cases of porphyria, erythropoietin is usually contraindicated. So what are we taking home? We've seen that erythropoietin is a very important adjunct to intravenous iron in bloodless medicine and surgery. You can't talk about parenteral iron without talking about erythropoietin. Erythropoietin is wonderful. It optimizes both the hematocrit level and also the tissue oxygenation, which are two pillars in bloodless medicine and surgery. And these are what most surgeons are more interested in. But beyond optimizing the hematocrit, erythropoietin has shown that it could improve wound healing in burn cases for burn patients, and it could also improve platelet and leukocyte production. Erythropoietin has also demonstrated such effects as protection, neuroprotection, bone healing, and muscle repair. Also, reduction of fat deposition and accumulation, especially in males. Hence, we need to study more of this erythropoietin and on its effects and continue to use it as it has proved to be very useful. Thank you for listening.
Thank you, Ms. Onyinye Isiguzo.